Good afternoon to everyone present here with us today. This is Shreyan from IGCP, today's moderator. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor, Dr. JPS Sahani. Sir is MBBS, MD, DM Cardiology, FIM SA, FACC, FECS, FCSI, FRCP, Chairman, Department of Cardiology at Sri Ganga Ram Hospital, Delhi. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is Cardiology Society of India Clinical Practice Guideline for the Management of Dyslipidemia. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, Sir.
Sure. Thank you, Sean. Thank you, Lena. Yeah, and sorry for my bad throat, but today I'm going to just good evening, dear friends, those who are with me today. I am going to discuss with you the recently published guidelines for the management of dyslipidemia under the banner of Cardiological Society of India. This is the first guidelines of management of dyslipidemia just published on 9th of April in Indian Heart Journal. Before that, we did not have any guideline. We only had the consensus statement from experts of the country, various cardiologists. They used to have their opinions, not based on Indian data, but on the expert opinion based on the world literature of management of dyslipidemia. So for the first time, 4 years ago, Cardiological Society of India president and the vice president, the people. I was the chairman of the Lipid Council of India at that time, and we decided to write guidelines for our country. And for guidelines, we know that we have to have data of our country. So long we did not have, so we took 4 years, along with my 22 cardiologist friends from all over the country, those who are expert on lipid management, to prepare this manuscript, which was finally published on 9th of April. So in this guideline, what we have done, we have looked into the Indian population's data. So this is the publications which has come in Indian Heart Journal now, is available online also, and print copy is also available. So why there was a need for a separate guidelines compared to the Western world? The most commonly used guideline globally at the moment is European Society of Cardiology 2019 guidelines, which is widely accepted by everyone in the world. But we needed our own lines. We also have agreed that we also having the same as the ESC 2019, but there are certain areas where we are different from them. And so we started looking at how we are different. One is that we get disease of heart disease or stroke 10 years earlier in our country, 10 years earlier in our country compared to that of the Western world. Like 50% of the people below the age of 50 years, they get heart disease, which is 3 times more than the Western world, where it is only 15%. And surprisingly, below 40 years, around 20% of the people have got also heart disease. So this was a important figure from our country. Secondly, we started looking that the risk factors which cause ultimately heart attack are hypertension and diabetes, which we get them in much earlier age. Secondly, tobacco consumption, besides the cigarette smoking, we have a peculiar problem of beedi smoking and also the chewing tobacco, which is again very specific for our country. Then we started looking into the central obesity, what we say truncal obesity, which is a component of metabolic syndrome. It is found almost in more than 40% of our population as against to 20% in Western world. So this was another important difference compared to the rest of the world. We have also got a special type of lipid disorder where we have got high triglyceride, low HDL cholesterol, and high small size LDL particle. Finally, we have our own data now of genetic causes of dyslipidemia, and one of the important one is the heterozygous familial hypercholesterolemia. And this, our own study, we found is much higher in our population, or more than 15% in like population compared to 10% in Western world. Lipoprotein is another genetic marker of dyslipidemia. Again, we found much higher in our population compared to Western world. If I look into the lifestyle of our country, we have a significant sedentary lives in metros and even in urban areas. We looked into the data on the cooking method. We found we have a lot of unhealthy cooking. We overheat the food, overcook the food and destroy the ingredient like minerals, vitamins. Being vegetarian, significant number of population, we found that there is a high consumption of carbohydrate food also, which leads to increased atherogenic dyslipidemia. So this understanding that we are different, started looking into our own data. So this guidelines bring for the first time the customized for Indian population. However, I must concede that at many instances, hardcore Indian data was not available, and we had to tweak the international guidelines of European Society of Pathology with help of expert opinions and wide experience of our renowned specialists in this field. We have good data on epidemiology, clinical trials where we have participated, and studies. In the absence of our own risk calculator, we use the risk factors for risk estimation. With this initiative, we have attempted to develop an India-centric clinical guideline for the management of dyslipidemia, building on the previous consensus statement. And we believe that this clinical practice guideline will offer the healthcare professional a type of very practical corner to be used in day-to-day clinical practice. Almost 24 chapters have been covered from epidemiology to medical adherence by my colleagues from different parts of the country. Let's start with the epidemiology. We look into the risk factors on 1,13,000 individuals from rural and urban areas between 2008 and 2020. And what we found, hypertension is present in 35% of patients, diabetes in 11%. But when you look into the lipids, it was 81% of the Indian population is suffering from lipid disorder, mainly because of the low HDL cholesterol. So that shows that we are much more prone for cardiovascular disease because of this reason. And when we look into the different regions of the country, what we found hypercholesterolemia or high cholesterol showed widespread interregional variability, with highest prevalence in the northern region, Kerala and Goa, and to some extent in West Bengal. The prevalence of high triglyceride, which is a very common component of dyslipidemia in our country, was again high in the regions with very little difference between urban and rural areas. Then we look at LDL cholesterol, similar to that of the high triglyceride. All of the country is red. You can see high of HDL cholesterol along with high TG, with very little difference between the rural and urban areas, and not much of interstate or interregional variation. Whereas bad cholesterol, LDL, on the right side component, you can see it, like total cholesterol, did show a variability with high prevalence in northern region, Kerala and Goa. When we look into the urban data, with the cutoff of LDL 400 for normal population, we found 50% of our population is having high LDL. Since we have got high triglyceride, we decided to calculate non-HDL cholesterol in this population. And non-HDL cholesterol is nothing but total cholesterol and subtract with the HDL cholesterol. That becomes non-HDL cholesterol, which is generally 30 milligram more than that of LDL. So the goal for normal population is 100 milligram for LDL and 130 milligram for non-HDL. And in non-HDL, what we found in the urban data from Dr. Gupta and colleagues, that more than 55% population has got non-HDL high. So there is a high prevalence of hypertension, diabetes, and high cholesterol. And that is one of the reasons why we are getting disease earlier in our lifetime. Now coming to the practical aspects what we thought we must teach our colleagues, physicians and clinicians and primary care physicians, how to manage the heart disease. So for that, we say, if a patient comes to your clinic with blood pressure or diabetes, we must look into the lipid profile of that patient. And depending on the lipid profile, we stratify the risk of patient, whether he is very high risk, moderate risk, low risk, or extremely high risk. So what we can find, extremely left side is a extremely high risk population where people they get atherosclerotic cardiovascular disease, recurrent episodes within 2 years in same territory, and also those who have got heart disease with genetic factor of familial hypercholesterolemia and elevated lipoprotein little a. Here we decided to keep the LDL cholesterol below 40 and non-HDL below 70. Whereas the most common group is the very high risk population and high risk population. Very high risk are those suffering from heart disease and or stroke or peripheral disease, diabetic patient more than 20 years with heart organ damage like peripheral neuropathy, retinopathy, nephropathy, and the hypercholesterolemia population. Here we decided to keep the LDL cholesterol below 55 as suggested by European guidelines, but non-HDL cholesterol is fine. Now, another area where we worked separately, what we found that, as I told earlier, that in our guidelines, compared to the ESC guidelines, we have also suggested to have proper target of not only LDL, but also of non-HDL, because our country has large number of patients with high triglyceride. So anybody who's got triglyceride above 150, don't only look for LDL, but also look for non-HDL. So coming to the third category, the high risk is the one where patient has got diabetes or patient has got hypertension with one more risk factors like dyslipidemia, smoking, aging, family history. So any one of this risk factor, if it is there, then it is better to keep the LDL cholesterol less than 70 and non-HDL less than 100. Whereas the low risk population of the one, those who have got no risk factor, or if at all they have a risk factor, it should be a single risk factor, but without any associated risk factor, probably there also we can say we can keep it below 100. But remember that in clinical practice, most of the patients with diabetes and hypertension have associated one more risk factor, and that's why in practicality, majority of the patient hypertension and diabetes will require to keep the LDL cholesterol below 70, which is a very important message which I want to tell you, because if we keep it below 70, then only we will prevent future heart attacks. So this was a little different compared to the Western world. Then we started looking at the second aspect, the patient who comes to you with heart attack, how to manage this population. We have suggested that whenever a patient comes with heart attack to the hospital, get admitted in CCU, the blood sample which we take routinely for biochemistry, hemogram, we should also take non-fasting lipid profile. And very important to know that. And here the question is that very important. Then acute coronary syndrome or heart attack patients are prone for recurrent events of repeat heart attacks and complication of heart attacks within first 3 months very commonly. And this 3 months is the vulnerable period where we should hit hard and hit early principle, either treat them with angioplasty or good medical treatment. But one of the component of good medical treatment is to reduce the cholesterol level. And for that, we have decided that to give them high doses of rosuvastatin along with azithromycin, 40 milligram, or give 80 milligram of atorvastatin with azithromycin to begin with, so that majority of the patients should reach below 55. If they are unable to reach below 55, then we should add another drug now, which is another non-statin drug called bempedoic acid, which is available to us that can reduce further cholesterol by 10 to 15%. And in that, we can repeat cholesterol again after 4 weeks. So here we have suggested to repeat the lipid profile every 4 weeks, because we have our own data from our country where we have found that the maximum effect of statin comes at 4 weeks, beyond 4 weeks, there is no further reduction of LDL cholesterol. So since we are in a hurry to control our lipids in such highly vulnerable population, we decided to start every 4 weeks so that we reach the goal as early as possible. But still, there will be 5 to 10% of patients who will not able to reach the goal in spite of taking all these three drugs. And in that situation, I think we should add PCSK9 inhibitor injections, or now we have got inclisiran, which is available to us. It has the advantage that this can be given only 2 injections a year. PCSK9 has to be given 26 injections per year, and inclisiran looks to be little more affordable. And with that experience, that if you add one of this injection to those population, those who are unable to reach the goal, then almost everyone will able to reach below 55. Now the question comes in mind that what to do? Shall we keep them on these doses forever? But here I must tell you that there are a good number, 10% of the population, those who may not able to tolerate statin because of leg pains or say myalgia. And in that situation, we have suggested to reduce the dose from 40 to 20 rosivas or 80 to 40 atorva, and then watch them after 4 weeks for repeat lipid profile. If the lipid profile is still high, then add bempedoic acid in this situation. Now, the other thing which we have suggested in this algorithm is that if a patient is more than 75 years of age and has got a kidney disease, then we should always start with 20 milligram of Arodiva and 40 of Atorva. And those patients, those who are already on statin group of drugs, we have suggested to load them with 40 milligram of Rosivas or 80 milligram of Atorva. So this is the method. So here we are a little different than European guidelines, but we have gone little ahead with the combination treatment so that we can reach the goal as early as possible. And this was based on our small study, which we did, and my colleagues they did. When we look into this heart attack population, we gave them high intensity statin, what we say, atorva 80 or 40 rosivas, along with HTMI in one group. The other group was given only 80 or 40 of statin. And then after 4 weeks, we started looking into the LDL cholesterol of less than 55. And we were surprised to see that roughly 50 to 55% patient only able to reach the goal if their baseline LDL cholesterol was above 110, which is quite common in heart attack population. Whereas if you start them with combination treatment, then more than 75 to 80% patient will able to reach the goal. So that was the basis why we have chosen a combination treatment. Now, there is another group of population which come to us. They do not have any heart attack, but they have stable angina. Here we are not in hurry because the annual rate of heart attack in this population is only 2 to 4%, not more than that. So here we suggested that non-fasting lipid is good enough, but start with high dose of statin. But the doses we kept is atorva 40 and rosivas 20. Wait for 4 weeks. If you're not, then instead of doubling the dose, we have decided to add HTMI. And this HTMI addition will have an additional benefit that you reach the goal early because it is much more effective compared to doubling the dose. Number two, you have less chances of having myalgia and also less chances of having new onset of diabetes. So so this combination works much better. If it is unable to reach, then we can add bempedoic acid. Before that, I forgot to tell you here in this acute coronary syndrome slide that there is another indication where we can reduce the dose of the 80 to 40 or 40 to 20 is a patient who has shown a rising trend of HbA1c. If the patient has metabolic syndrome, central obesity, and his HbA1c is in a pre-diabetic range around between 6 to 6.5, and dose of statin, there is a rising trend of HbA1c. A patient is developing new onset of diabetes. Again, we have suggested here to reduce the dose from 40 to 20 rosiva, 80 to 20, 40 atorva, and add bempedoic acid, which do not increase the blood sugar level. So after discussion, algorithm not given by. Now also we have suggested to have uniform reference range for the laboratories and point of care system in the emergency department and clinical labs. So this is what we found. Then come to the another part component management is the management of high triglyceride. So as I discussed that whenever a patient has triglyceride, it is normal. Now here we must always look for if a person is diabetic or a patient suffering from thyroid, you have to control both diabetes and thyroid. And after that, if you see TG is still above 150, then of go for the lifestyle modification. And in that, most important thing is to reduce the sweets or high carbohydrate diet, reduce alcohol, tobacco association should be there, physical activity, and if you're obese, reduce the weight. By this method, I think significant number of patients will able to reach the LDL, triglyceride below 150 or non-HDL below 130. Sorry. In spite of everything, a lifestyle modification and control of diabetes and thyroid, if the triglyceride levels are high, above 150 and below 500, here our fear is of heart attack because there is a cholesterol called remnant cholesterol present in the triglyceride molecule, which is reason why we decided that whenever you have a high triglyceride, always calculate non-HDL cholesterol, not LDL cholesterol. LDL cholesterol will not carry the remnant cholesterol present in high triglyceride. Non-HDL cholesterol has got both components. Remnant cholesterol which is present in high triglyceride. So our target in all this in this algorithm is basically non-HDL cholesterol. So the patient has diabetes with multiple risk factor or suffering from heart disease or stroke, then I think in spite of lifestyle modification, I think we have to increase the doses of statin and non-statin drugs like ezetimibe or bempedoic acid to achieve the non-HDL targets of less than 85. And in that, if not achieved, then we generally say you give EPA or IPE, which is a icosapent ethyl. It is a fish oil component. Fish oil has two, EPA and DHA. We do not want DHA. The EPA component is beneficial, and clinical studies have shown if you add to this population less than 500 and along and having suffering from heart disease, then if you add this group of fish oil, IPE only, then there is a further reduction of heart attack. If the triglyceride levels are above 500 and or 1000 or maybe beyond that, then the fear is not of heart attack. Fear is because of pancreatitis. It is because the large chylomicron particles which are present in high T triglycerides, they plug the pancreatic vessel and causes the which is the third commonest cause after alcohol and gallstone. Here we have suggested to use not only the lifestyle modification but slightly more intensified, very low fat diet, and here the role of fenofibrate comes for the first time. This is the drug which is very useful in such situation to reduce the triglyceride below 500. We can use the fish oil, omega-3, which I have just discussed, and we have another drug now available called saroglitazone, which is now our own drug, our own research product, and we found that is very useful in diabetic patient with high TG or patient those who got fatty liver with high triglycerides. And these drugs have been very found to be very handy in controlling the triglyceride levels or the bad, the non, what we say, the remnant cholesterol present in triglyceride. But there are maybe a lot of population, those who will still continue to have very, very high triglyceride. And in that now, there are a new group of drugs coming up. The vonacerone is available in Western world. Evinacumab is also available. So these are the drugs which are experimental drugs which can be used. So triglyceride management, we have made it a little simplified. Lifestyle modification, control of diabetes, use statin and non-statin for heart or diabetic population, add fenofibrate in higher doses, and add saroglitazone if needed. Then coming to the genetic part, the area which remained untouched for years together in our country. And we, for the first time, along with my professor, Dr. late I.C. Verma, we have done a lot of Gangaram we found there are two varieties of familial hypercholesterolemia. One is the heterozygous, which is much common, 1 in 250. They get very high LDL cholesterol levels from 160 to almost 250, and they get heart attack between 4 to 50 get very commonly. Homozygous varieties, very rare, 1 in 1 billion. Disease come in first and second degree, which is now, how to diagnose this condition? For physicians' knowledge, what we have decided to use Dutch Lipid Clinical Network criteria. And what here it is based on scoring system. If you have got a young heart attack, men less than 55 or women less than 60, which is very common, as I told you in my first slide, 50% of the Indian population belongs to this category. Here we found that you get a score of 2. If you have got a family history of young heart attack or stroke or sudden death, you get another 1 point, 3 point. If your cholesterol levels are high, above 160, up to 190, you get 1 point. Above 190, you get 3 point. So straight away getting 6 point become very easy. Although the gold standard of diagnosis of familial hypercholesterolemia is genetic testing using the functional mutation of LDLR, ApoB, and PCSK9 gene, where you straightway get 8 points. So anyone who has got definite means above 8, 8 and above 8 is definite. The probable is between 6 to 8 points. So if a person has got above 6 points, which we call potential FH, has been validated with genetic study and found that which correlates very well with the genetic markers. So this is how we diagnose FH. Now, what is important? There are people, those who are on statin already. So the scoring is for statin day population. So we have got for each statin, there is a what we say adjustment factor. Like for example, one of my patients, he was on 20 milligram of Torva when he came to us with heart attack, and non-fasting lipid was LDL was 110. So for 20 milligram of Atorva, the adjustment factor is to multiply with 1.8. So when we added 1.8, his score, the level came to 198, and 198, according to the Dutch Lipid Clinical Network criteria is 3 points. You can see here above 190 is 3 points. So that's how we can calculate these statin, those who are on statin. And so the most important thing is that every patient of FH whom we are diagnosed, the cascade screening is important. Because the reason is the treatment is not complete unless you do a cascade screening. That means the lipid profile of children and family member. And we found that if the levels are high, then they are generally carrier of the disease, and they are unaware and they are prone for premature heart disease. So what we found that by diagnosing a case of FH, we do not identify a patient, but a family at risk. And that is very important. And our own study, which we did in our hospital and northern part of the country, we found the definite and probable group of FH. That means potential FH was there almost more than 15%. In our study of 1,200 patients, is almost 17% now. It's very high. And we started looking into the other risk factors which are there in heart disease population, like diabetes, smoking, hypertension, and cholesterol level. And what we found interestingly, for definite population score is 8 or probable score is 6 to 8, their associated risk factor of diabetes, smoking, hypertension was less compared to possible and young heart attack patient without clinical diagnosis of FH. Whereas when we look into the cholesterol levels, they were very high in the definite and probable group. That's what we have learned now. That if a patient comes to you with heart attack, a young heart attack, and he does not have smoking history or tobacco consumption history, or he does not have diabetes, then always think about familial hypercholesterolemia. The importance is that you are not only treating the index case, but also identifying some of the carriers in the family, those who are suffering. If we whom treat them, then we will be able to prevent premature disease. So this is the algorithm we look for. Any young heart attack patient, less than 55 men, less than 60 women, apply Dutch criteria, score is 6 and above, he is clinically heterozygous FH, treat them with lifestyle modification and bring the LDL below 55. And majority of the patient I have found, they use high dose of statin and HTAPI. Even some of them, they require bempedoic acid. If they are not controlled, then of course I've just told PCSK9 inhibitor, Evlocamab, or inclisiran, which is now catching up as one of the drug of very popular drug to be used for reduction of the cholesterol level. The treatment does not finish here because we have to look for cascade screening of children and sibling. If the levels are high in cholesterol, we may do only cholesterol or we can do the genetic testing. And if we found their carrier, even if they have no symptom, we should manage them with statin in low to moderate doses to keep their LDL cholesterol below 170 milligrams. So this is how we do. The other we found was lipoprotein A, which is very highly prevalent in the world now. And this is seen that approximately 20% of the world population has got LP above 50 milligram per deciliter or above 125 nanomole per liter. 1.4 billion population is having such genetic problem. And in India, unfortunately, we have 25% population having LP above 50 compared to 15 to 20% in Western world. And we have now evidence that if you have high LPA, which is inherited a factor by looking at the epidemiological study and randomization studies, have shown that it increases heart attack by 3 to 4 fold, aortic valve disease by 3 fold, stroke by 1.6 fold, heart failure, and cardiovascular death very high in this population. And unfortunately, at the moment, there is no specific drug for that. The statins, the HMI, bempedoic acid do not cause any reduction of LPA. PCSK9 inhibitor and inclisiran both have shown can reduce by almost 25 to 30%, but that may not be enough. So specific drugs are now available. The ASO, pelacarsen, and olpasiran is now a small interfering RNA product. They are found to be very powerful. They reduce the LPA by 80 to 90%. And we have to look for now how they are going to help. So what we have learned is that the LPA is a risk factor, is an amplifier to manage other risk factor very aggressively, hypertension, lipids, sugar, and obesity and smoking. But this specific drug, which is called antisense oligonucleotide ASO, is being evaluated at the moment in a study called Horizon, where we are participating. And this drug has been found to reduce LPA by 80 to 90%. And in that situation, what we have found that if he reduces this drug, there will be this drug has got very little side effects, and the very effective drug do not cause any problem. Now, we also looked into our own data in our country. To summarize the data, that we look into 1,000 patients of atherosclerotic cardiovascular disease, analyzed them, and found that LP was present in the younger population much more than the elderly population, and it was also associated with severity of disease. And in patients, those who got familial hypercholesterolemia, associated lipoprotein level was much higher, is above 40%. So this is our own study, which we have incorporated in our guideline. We have also included a very extensive a table ready reckoner for the physician to go through all the medicines which we use to control lipid disorder. What is the efficacy? What is the side effect? What are the doses? And all those things have been there in a single page. It's easy for physicians to refer to. And finally, about the dietary management, we also made it very handy based on our population, our own diet throughout the country. And a principle of diet has been also given here in this chapter. We have also incorporated that sugar and high carbohydrate diet causes much more heart attack than modest consumption of fats and saturated fat. So that has been which that you have to refer to the major journal because of paucity of time. I will not go into details. So that in question answer we can have some discussion. And then another chapter which is very important in other guidelines is the dyslipidemia in young population between 18 to 40 years. As I told you, 20% of the heart attack in India are less than 40 years of age, so their treatment do not differ from that of adult population. The patient, children, those who have got LDL above 190, has to be treated with statin drugs. Patient, those who have got LDL above 100 and they are having multiple risk factors like diabetes, hypertension, or premature family history, they have to be treated with lifestyle modification and if needed, small dose of statin to keep the LDL below 100. Nutraceutical has been also given a chance to play, although they're not supported by many studies, but that people are using this drug because it is a practically harmless drug. Patients, those who are the carrier of familial hypercholesterolemia, there we have to use moderate to small doses of statin to keep the LDL below 135 for children and below 100 for adult. And management of triglyceride in young population is not much of different compared to that of adult population. The other area, which is a disturbing area for our country, maybe globally also, is the area of adherence to the drug therapy. And that is what we found in the two studies of 575 patients that very small number of patients are on high intensity statin and that's why they are unable to reach the target population. So you can see there 70 to 80% of people are not achieving the target of less than 55. Our study, which was not yet published, is the Gangaram Hospital adherence study of 3,700 patients. We found that most of the patients, even the tertiary care center and high-end center, they start with high dose of statin, but down the line, over 3 to 6 months and 1 year, we found surprisingly only 30% of the patients were on high dose of statin. Majority of the statin was reduced, the reason for which is unknown, but it looks like it is the physician's fault what they do because we know that if there is a side effect or there is a new onset of diabetes, we can reduce the dose. But those who are tolerating well and keeping their target below 55, there is no need of reducing the drug. But most of the physicians have reduced the drug, and even patients looking into the media, sometimes maybe cost factor, they try to reduce the drug, and which ultimately leads to increase in LDL to above 55, causing recurrence of cardiovascular events and even stent blockages. So, in conclusion, dear friends, what do you want to say? That for the treating physician, this executive summary, which I have just discussed with you, the first Indian guidelines have been now incorporated, and that is very important, and that will be very useful for the Indian doctors to manage dyslipidemia based on Indian population's research. We have tried to cover each and every aspect of the dyslipidemia management specific to Indian population. However, many areas, the experience of the experts were taken and the guideline of European Society was used for algorithm. And there are not much difference, as I said, for European guidelines, but there are certain areas where we have been shown some changes. So what we believe that it is always good to pick up bad cholesterol earlier the better, and always keep it below 55 or 40, depending upon the risk of the patient. So what we believe is to keep it lower the better, and then keep it low forever, because otherwise you'll get premature heart disease. So longer the better. And finally, what we found, together the better. That means combining statin and non-statin drugs together will be required in significant number of patients to manage the cholesterol. So I'm thankful to my colleagues, those who have contributed with me. Thank you very much. Back to Sriyan and to Ananya. I'm
Thank
finished
you,
with my
sir.
talk. If there are any questions,
Yes, sir. We do have some question if you like to take that up.
George.
Yes, sir. So, sir, the first question is, can you share any case studies or
Yeah.
clinical scenario that highlights challenges or best practice in the management of dyslipidemia in real world clinical practice?
Yes, there are patients, those who are suffering from heart disease, and we have found them their cholesterol levels are very high. And when we start them on statin in high doses, along with non-statin drugs, some of the patients do not uh, tolerate statin because of myalgia. They get leg pains. And then what happens? The patient stops the drug or reduces the drug, and which leads to uncontrolled cholesterol. and which ultimately causes the heart attack. This has happened with one of my patients only 3 months ago. Same story, family, brothers, two sisters. So both the sister and brother and their father, they all suffered from heart attack in young age. And the cause was familial hypercholesterolemia. And we found very high level of cholesterol, about 200 of LDL in all brothers sisters. So I put them on statin, and same story. The one of the sister could not tolerate, so she stopped her on own. And one middle of night, I got a phone call that she developed heart attack. The cause was uncontrolled cholesterol. Since we have statin intolerance, we have got many other non-statin drugs like HTMI, bempedoic acid, inclisiran, and also glucamab available to reduce the LDL cholesterol. So the crux of story is that for blockage of the artery, what enters into the formation of plaque or blockage of artery is the LDL or non-HDL cholesterol. Who pushes it? Hypertension, diabetes, smoking, stress. They push LDL and non-HDL into the arterial wall, which ultimately causes the blockage of the artery, what we call in medical term atheroma. So that is what we should learn, that we should try to keep. So that's the reason why we have suggested that all the laboratories in the country should have a uniform reference range for that. And they should not say their LDL below 100 is normal. That's fine. But that is for general public. If a person is diabetic or hypertension, there should be asterisks there. And in the note, they should write, if you're hypertensive, you are diabetic, keep it below 70. And if you're having heart attack, stroke, keep it below 55. So this type of information is very important. Sometimes patient gets misled by the reference range in the investigation report where it is written LDL should be less than 100, which is good, but for general public, not for heart attack patient. So these are the suggestions which we have given in our guideline.
So there is one last question.
Yes.
What are the primary
Ah,
pharmacological option for the treatment of dyslipidemia, and how do you decide which medication to prescribe for a particular patient?
see, the dyslipidemia, commonest is the LDL or non-HDL cholesterol high, where we have to use statin. And if statin is unable to reach the goal alone or because of intolerance, then we use non-statin drugs like HTMI first. If after adding HTMI also cholesterol is not lowered, then we give bempedoic acid. And there are rare cases where we have to use the injection inclisiran and also injection evolocumab. They are available. They are but costly drugs for our population. But they are available and they will definitely reduce the cholesterol level. But if a patient has high triglyceride, if the levels are below 500, then among the drugs, we always give statin and non-statin along with fish oil, EPA, and if the triglyceride is above 500 to 1000, then we add fenofibrate. And also now we have another drug called saroglitazole that can be given to such population to reduce their triglyceride level to prevent future heart attacks.
Thank you so much, sir, for answering all our questions. And before concluding, sir, any last remark from you?
I want to tell the colleagues and the general public that the most important risk factor for blockage of artery is cholesterol. I mean, it causes heart attack, it can cause paralysis, it can cause limb disease causing amputation. So blockage of the arteries because of cholesterol. Now, what's the important second message is that all the three important or four risk factors for heart disease or vascular diseases, hypertension has some symptom, diabetes has got some symptom, smoking and tobacco you can identify, but the LDL cholesterol is a true silent killer because it do not have any symptom. There is no symptom unless and until you test it. That's why in our guidelines for general public, we have recommended when a child goes from school to college at the age of 18, should get his blood pressure, sugar and cholesterol test, that stage, because we get disease earlier. So we can identify early abnormalities in the society, even in younger population, and try to modify their lifestyles so they can control this risk factor if they have developed, unfortunately, in a younger age, in very early stage, so they do not get heart attack in a younger age. So these are two my important messages that lipid profile, lipid is the true silent killer. One should assess it. Without that, symptoms will not be there. It will take you straight away to the coronary care unit, to the hospital for heart attack, with heart attack or stroke.
Thank you so much, sir, for joining us today. And with your permission, sir, I would like to conclude today's session. Thank you.